Susan actually needs no real introduction. She is the secretary stroke treasurer of our society, and she's busy with her PhD actually on HIV and TTP. And we in South Africa are unfortunately in the position where we see so many cases of TTP that we have become experts. And I go to international meetings, and the expert stands up and gives a plenary talk, and they've seen less cases in their life than we see in a year here. So Susan is going to speak to us today, and I know it's not really for unfortunately the private sector don't really see that much of it, but if they're not aware of it, they won't recognize it. So Susan, we're very grateful today that you're going to enlighten us on this mini epidemic that we're seeing of HIV and TTP. Thank you very much, Susan.
Good morning and welcome to all the delegates to the first virtual South African Society of Thrombosis and Hemostasis Congress. So without further ado, I want to proceed because a woman has more words than that will only fill 15 minutes of a presentation. But I want to ask the permission from the chairman, who is currently not with us. So I'm going to ask Professor Jacobson if I can maybe change the title of the talk. And I want to change the title of the talk slightly. There we go. Okay. So back to where I was. I wanted to change the title of the presentation to HIV and TTP-like syndrome, but the problem definitely continues. So TTP, as we know, is an aggressive thrombotic microangiopathy with multi-organ dysfunction due to widespread microvascular thrombosis and resultant ischemia. The mortality rate approached 100% prior to the introduction of plasma therapy, either in the form of plasma infusion or plasma exchange. And this occurred in the early 1980s, which was quite recent. The pathogenesis of the condition relates to an imbalance between von Willebrand's factor and its cleaving protease, ADAMTS13, which was only discovered in 2000, so both very recent events. On the screen at the moment are all the thrombotic microangiopathies that are known to us. With TTP in the first row, we're also talking about hemolytic uremic syndrome, as well as disseminated intravascular coagulation. But when we are talking about this condition occurring in our patients with HIV infection, we are definitely in the realm of acquired TTP with ADAMTS13 autoantibodies, possible complement activation, and endotheliitis all contributing. So a word on von Willebrand's factor. This multi-protein is expressed by endothelial cells and platelets and surveys the vasculature with hidden platelet binding sites. This protein then unravels when it finds defects in the endothelial cells and bind to the underlying collagen. With exposure of platelet binding sites, which recruit platelets, and size does matter, the larger the von Willebrand's factor multimers, the more hemostatically active they are. So we can think of von Willebrand's factor as a superglue. When it comes to ADAMTS13, thank goodness for acronyms, because it actually denotes the term a disintegrin and metalloprotease with thrombospondin type 1 repeat member 13. So I hope to be invited back to talk about the other members of this family as well, eventually. This protease regulates the size of von Willebrand's factor in that it cleaves von Willebrand's factor, especially in the microvascular. And this cleaving process is a controlled, multi-step and very complicated process. And we can think of ADAMTS13 as a pair of sharp scissors. If we just go back to the von Willebrand's factor pathway, we know that von Willebrand's factor is produced from endothelial cells as high molecular weight von Willebrand's factor molecules cleaved by ADAMTS13 to release smaller, less adhesive multimers. When things go wrong, and there is an imbalance between von Willebrand's factor and activity of the cleaving protease ADAMTS13, a microangiopathy ensues, fragmentation of red blood cells as they squeeze past microvascular thromboses, which consists of von Willebrand's platelets, resulting in fragmentation of red blood cells, early red blood cells in the circulation, thrombocytopenia, and multi-organ failure due to ischemia. In the past, we were told that in order to diagnose TTP, we have to look for a pentad consisting of renal dysfunction, CNS abnormalities, and fever with associated thrombocytopenia and microangiopathy. Things have, however, changed, and now we know that we only need two components, thrombocytopenia and a microangiopathy, in the correct clinical setting. When I started out in hematology, actually in medicine, we were taught that TTP was an extremely rare condition. It was orphan or rare condition with a very low prevalence. The pathogenesis related to deficiency of ADAMTS13, and that D-dimers were expected to be normal. But things have changed, and this condition is definitely not rare any longer. We have one or two at the Charlotte Maxeke Johannesburg Academic Hospital, usually related to underlying infection with HIV. The pathogenesis, lots of question marks. There's heterogeneity as far as ADAMTS13 deficiency is concerned. We are postulating that endothelial dysfunction without pouring off von Willebrand's factor and activation of platelets play an important role in the pathogenesis of this condition that we now encounter with regularity. And D-dimers in this condition is often increased, denoting localized coagulation activation. And we could probably start talking about an HIV-related TTP-like syndrome. So just a word on the often forgotten endothelial cells. Endothelial cells are more than just a barrier in that they display heterogeneity in structure and function, time and space, health and disease. They have metabolic synthetic functions. They react as para and endocrine organs. They regulate various components of hemostasis, as well as the immune and the inflammatory responses. And they play a pivotal role in angio and vasculogenesis. And they also store and release von Willebrand's factor. Endothelial cells played an important role in disease processes that are very well known to all of us, such as atherosclerosis and metastases of malignancies, as well as thrombosis, and most probably also in TTP and TTP-like syndrome. Endothelial cells are not friends with HIV, and various mechanisms of damage of endothelial cells in patients infected with HIV have been documented. HIV proteins create monocyte chemotaxis and production of reactive oxygen species that can damage endothelial cells, ARV drugs, gut microbial translocation, co-infection with various viruses, all result in endothelial damage. And then there is still the controversial concept of whether endothelial cells themselves can actually become infected with HIV. And then we also have to remember that HIV activates the complement system, which can also possibly result in endothelial damage. So the complement system has been put onto the screen. I have to maybe spend one slide talking about complement. Complement consists of more than 50 soluble and membrane-bound proteins, which play an important role in the innate and the acquired immune system. And complement is definitely activated by HIV, in that HIV envelope proteins can activate the classical pathway of complement by activating the C1 component of complement. HIV antibodies are potent activators as well of complement. The surface proteins of HIV in the form of GP120 can activate the lectin pathway of complement, which culminate in inflammation and the formation of the membrane attack complex with cytotoxic T cells, all having adversarial effects on the endothelial cells. And then used to the concept of TTP-like syndrome by Chang and his co-authors in a paper entitled TTP-like syndrome, novel concepts and molecular pathogenesis of endotheliopathy-associated vascular microthrombotic disease. So if we just unpack TTP-like syndrome a little bit further, we see that we have to think of the primary event of classical TTP versus TTP-like syndrome to be different. Classical TTP, whether it is hereditary or acquired, involves a severe decrease in ADAMTS13, which either relates to genetic mutations in the hereditary form or autoantibodies in the acquired form, but there is a significant decrease in the activity of ADAMTS13. In TTP-like syndrome, the primary cause are disease processes that we encounter in our critically ill patients: infection, polytrauma, malignancy, transplant toxins, and also probably HIV. The secondary events in these two conditions are similar in that they are excess von Willebrand's factor, but the pathogenesis is different. And in TTP-like syndrome, the increase von Willebrand's factor concentration relates to complement activation, inflammation, and endothelial injury with excessive release of von Willebrand's factor, as opposed to decreased cleavage by ADAMTS13. The tertiary events in these two conditions are similar in that we have a microvascular thrombosis, but in TTP-like syndrome, this is associated with a cytokine storm and inflammation. The clinical manifestations are also slightly different. The hematological features are similar between the two conditions, but the clinical features, we see that in TTP-like syndrome, inflammation and consumption of coagulation factors and end organ damage is more common in the described TTP-like syndrome by Chang and his colleagues. The laboratory features similar, but the ADAMTS13 levels are thought to be different between these two conditions. Both conditions, however, respond to therapeutic plasma exchange. We can put all of this in a very erudite flow diagram, and we can see that the pathogenesis of TTP-like syndrome involves various conditions, and we can possibly also say that it involves HIV with activation of complement, ensuing endotheliopathy with resultant inflammation and microthrombotic pathway activation and TTP-like syndrome.
Susan, you have 30 seconds.
That I don't really have time to talk about therapeutic plasma exchange. So I do have my takeaway message in that this condition is not uncommon any longer, that there's mortality despite plasma exchange. The exact pathogenesis has not been well elucidated and it requires further research in order to optimize the therapy and improve the outcomes of patients suffering from this very serious disease. Thank you very much.